job you are doing in Zimbabwe to improve mental health awareness. Mrs. Shunga, thank you for being a mental health advocate. We commend all the advocacy activities you are doing through your NGO, Work With Me Foundation, especially for sharing personal experiences. Your presence here is a step towards in helping to make a difference. Special thanks to International Federation of the Red Cross, a long-standing partner of Ecobank. Mental health is an area of expertise for you, and we look forward to getting insight from Dr. Ben about what you're doing on psychosocial support. Thank you, Michael Njenga, for the great job you're doing with CBN Global Disability Inclusion in ensuring that the rights of people suffering from mental health are respected and our laws protected. Once again, my appreciation on behalf of the entire Ecobank Group to every one of you for joining this webinar. I do believe that it will shed light on mental health disorders in Africa, and more importantly, what we need to do about it. So, ladies and gentlemen, let's now take time to talk and act on mental health. Thank you for listening.
Mr. Ade Ayeyemi, CEO of the Ecobank Group, thank you very much indeed for that stirring address and for putting your considerable weight behind this particular campaign on mental health this year. You're so right. It really is still a taboo in many areas of Africa. But it's time to talk. And we're seeing people opening up. And we're recognizing that if you have a broken leg, you go to the doctor and get it fixed. If you have a heart condition, there is no stigma. There is treatment for that. Nobody will say you are possessed or there's witchcraft. So why should it be any different when you may have difficulties with your mental health? So, sir, thank you very much indeed. And we will now try and pick up the baton and go in for a deep dive into mental health. And I'm pleased to welcome Dr. Chido Rafa Madzvamutse, who is a specialist psychiatrist in Zimbabwe, as you mentioned, and a Mandela Washington Yali Fellow. Dr. Chido, thank you very much for joining us.
Thank you, Henry, and thank you to the Ecobank Group for this wonderful opportunity.
First of all, let's get a definition out of the way. What should we understand by the term mental health, and what are the most common forms of mental illness or mental ill health?
Thank you. I think that's a great question to start with, because people often connotate the word mental with illness, when in fact mental health is an aspect of health, which is really defined as a state of well-being in which an individual is fulfilling their full potential and is coping with the usual stresses of life and contributing meaningfully to their families, to their communities, to their nations. So that's what mental health actually is. And yes, there can be problems with our mental health, and these can be due to biological causes, can be due to psychological issues, can be due to social issues, as the CEO was talking about COVID, that brought about a lot of social stresses that can actually then lead to mental health. Common mental health problems, the most common is actually depression. When people think of mental health problems, you think of psychosis, someone who is having hallucinations, delusions, and is not stable, maybe is homeless. That's what people sort of associate with mental illness. But to sort of really demystify that, the most common mental health problem is depression, which can happen to 20 to 30% of the adult population in their lifetime. So amongst us all, I was looking at the numbers. I think we're almost 1,000 people. 20 to 30% of us in our lifetime may get depressed. So that's the most common one. And it's really a mood disorder where you feel sad. There's nothing that has necessarily triggered the sadness. And you feel demotivated, you feel fatigued, you feel tired. And there are a number of other symptoms that then come with that. Anxiety, also very, very common, follows really close to depression. And then we then come to alcohol and substance use problems, which people don't always consider as mental health problems, but they are. They are actually one of the most severe sort of contributing factors to mental ill health. Then we then get to other things like psychosis and the severe mental illnesses like bipolar and schizophrenia, which are actually much, much less common than depression and anxiety, like I've mentioned.
And I used to be a mental health act manager for some years in a large hospital in the south of London where there were many Africans presenting with mental ill health. And the most stigmatized conditions tended not to be depression, but to paranoid schizophrenia, for example, or bipolar disorder. Why would schizophrenia and maybe bipolar disorder be the ones that attract most stigma? And is that the case where you are in Zimbabwe and in other parts of Africa, that there are some conditions that are more stigmatized than others?
Definitely. People will often want to say, I'd rather be, please tell me that I'm stressed, I'm overstressed, I'm burnt out, rather than actually giving a term to it. And that's actually one of the problems with mental health literacy, that we don't have enough mental health literacy in Africa. Many times we don't have enough informational material in English and in our local languages, so that people can access that information and actually understand what these conditions are. And you know, stigma is, we fear what we don't understand. Once you start understanding something, you're less likely to be so afraid of it. So the psychotic mental health problems, yes, will attract a lot of fear, particularly in Africa, where we attribute illness slightly differently than in the Western model. And that's something that we need to acknowledge. It's part of who we are. So when someone is ill, we are more likely to, yes, maybe acknowledge some of the physical issues, but many times in many African communities, we emphasize the spiritual issues, the cultural issues that could be going on with that. So that's where the stigma usually comes from, because it's like, why are you behaving like this? Something must be wrong culturally, in the family. There must be witchcraft, because of the way we sort of try and find meaning for what is happening. So I think that's something that we need to work on in terms of fighting stigma, is first really fighting disinformation. So people really need to know that some of these conditions, particularly the psychotic ones, have got a strong genetic linkage. And this is not anything that's someone's fault or someone's sort of bewitching you. Just like diabetes can be genetic, hypertension can be genetic, this can also be genetic. So that's something that we really need to work on.
Dr. Chido, you've talked a few moments ago about some of the common signs of the common illnesses. But at what point should somebody know or recognize that they need to get help? And what are the dangers of leaving something untreated for too long?
Okay. So an old mentor of mine, she passed away this year, Dr. Niwatua. She was one of the first female psychiatrists in our country. She used to say, if you leave a boil for too long, if you leave a wound for too long, it's going to also take a really long time to heal. So it's the same with mental illness. If you neglect it and you take years to get treatment, it's going to take a long time for you to then also get better. So it's very important that we have early intervention. And early intervention comes from recognizing symptoms. So functionality is one of the biggest issues that we look at in terms of psychological and mental ill health. So when you feel like you're overwhelmed, when you feel like you're not when you see that your family member is not as functional as they are, that's already a sign we need to get help. And functioning is sleep, functioning is appetite, functioning is energy levels, functioning is ability to concentrate, ability to hold down a conversation. All of those, they seem like simple things, but already you're saying, oh, there might be a problem. And that's why we say, let's talk about it. Let's talk about it is not let's go to the psychiatric unit and see Dr. Chido. Let's talk about it means in the family. Let's open up and say, okay, are you okay? How can we help? And sometimes the simple changes within the family can make a great difference, and it's part of the treatment already before we even get to the psychiatric unit and the psychiatrist.
Right. Okay. So the family and the support networks, initially the informal networks, but what about further treatment? Imagine if you're in Harare or you're in Lagos or Kigali, and you've got your family network and it isn't quite enough. You're still feeling lethargic. You're still feeling anxious. You may be even getting auditory hallucinations if it's a particular presentation. what about the next stage of treatment? Because people often fear the treatment. It feels scary.
And I think that's it's so true, Henry. I think the problem is it's not just the patients who are stigmatized in mental health. It's the practitioners, it's our hospital units, it's everything. It's a stigmatized area. Many psychiatric units are separate from the rest of the hospital, far away from everybody else. And already imagine you're saying, "Big, go that side, go to that hospital that's far away from everybody else." And it's like, something must be seriously wrong with me by now. So yes, one of the first things to do is go to your nearest health practitioner. So this is something that's still work in progress in Africa, and these are community services that are starting to happen. Many African countries are starting to recognize that with our limited budgets in our countries, the best investment is in our community services, so that when someone pitches up at the clinic, they can start to get help there. Many of the medical practitioners, the registered nurses who man the clinics, and our general practitioners have had some training in mental health. It might not be very extensive, but it's enough to recognize the problem and start to engage someone in treatment. So the first port of call would be your nearest health worker. And if you're not getting help from there, then you can insist on a referral to the next level of care in your setting. And this obviously differs in the different countries. But the first place to always come is to the nearest health worker. There are now some really great programs with lay counselors in the clinic levels, at the community levels, that are hopefully going to gain traction, because we need that in Africa, where we may not have a lot of fancy hospitals, but at the clinic level, at the community level, if our community health workers and our nurses are more empowered, that would be fantastic. And in many countries, that's starting to happen.
Excellent, Dr. Chido. We are still in the grip of a COVID-19 pandemic. Despite the vaccine rollouts, there are still problems, particularly in the global south, where in Africa, I'm told, across the whole continent, an average of around 3% of people have been double vaccinated. And then we still have the ongoing issue of mental health, because enforced lockdowns, lack of access to regular networks, income has been hit. How would you say COVID-19 has specifically impacted the mental health of the Africans in the research that you've done, and also at your level in Harare and around Zimbabwe?
So COVID-19 had a twofold effect. When we were busy trying to flatten the curve, remember flatten the curve about 18 months
I do remember that mantra, flatten the curve. Services, flatten the curve.
Yeah, so we were flattening the curve. But as we're doing that, a lot of mental health professionals were cringing, because we almost saw the surge of mental health problems that was going to come from that. So we started off with social distancing. I'm glad that WHO has actually changed. They're now saying physical distancing, because we are social beings. We cannot be isolated from other social beings. It's very important that we stay in connection. And that connection doesn't necessarily have to be physical. We are not doing this conference with 1,000 people here from different places, but we're connecting as humans, as people. And that's very important for our mental health. So that was one of the problems, the sort of the necessity of the isolation. It was necessary, but unfortunately it came with its consequences. And sometimes some people, because of their nature, they're vulnerable by nature, were very, very isolated, and that then also put their mental health at risk. So things like depression can be actually a disease of loneliness as well. You are more at risk if you are alone, if there's no one who's coming to see you. Imagine if you're an older individual, particularly the older individuals. We were told, don't go and visit Granny. You might bring COVID to Granny. But Granny expects your visit, is looking forward to your visit, and the grandkids and everything. And that's part of maintaining her mental health as well. So all of that sort of stopped, and that was a bit of a challenge. Of course, I think most people have now sort of adapted, and we start to see Granny on Zoom, but we're trying to continue the social interaction. So that was one, social isolation. And then the financial stress. Stress itself is a risk factor for mental health problems, either for things like depression and anxiety, but also for triggering other mental health problems. So the amount of stress that people have been under because of incomes that have sort of been cut is an issue. Then that also obviously increased the incidence of depression and anxiety, and worsening of symptoms of those who already had mental health problems. And then the grief. we cannot underestimate the impact of grief. As Africans, we grieve well. I think we
Yes.
really have a community way of grieving, and that really helps, to support us, each other. And that can be a challenge now when you're told you can't attend the funeral, you can't do your body viewing, you can't do your wake at home and sing all night as many of the African tribes sort of do. It really did affect people, and it caused a lot of stress, and people feel like they didn't do right by their relatives. And this is stuff that's going to continue to be an issue as the years go by. So that's something we need to be quite aware of, complicated grief associated with these problems. And then lastly, the disruption of services. So COVID obviously took center stage. Even areas like HIV and TB suffered, and those areas usually don't, but they suffered, and let alone mental health. So the services was disrupted. It was considered, is it necessary for you to come in for your review? If it's not necessary, stay at home. But sometimes someone looks forward to that review, to just talking to the nurses and the doctors and letting stuff off their chest. So that was also an issue.
Dr. Chido, what can I say? But that was a tremendous intervention. Thank you very much indeed for handling all those questions. I put you in the hot seat, and I suspect the 1,000 people watching us, listening to us all around Africa and beyond will have questions for you, and they'll be able to put those questions to you and our other speakers in the questions and answers session in about 25 or so minutes' time. For the moment, Dr. Chido, thank you very much indeed. And friends and viewers and listeners, if you're checking us out on YouTube or Facebook or any other platform, just use the chat box and you can fire your questions over, and we'll try and respond to them a little bit later on. We're going to move now to a panel of specialists, and they'll be discussing the issues and challenges and possible ways of supporting those who are struggling. And because although mental health has risen up the agenda in many countries, partly driven by black celebrities like the gymnast Simone Biles and the tennis player Naomi Osaka, who've said they needed to take time out for their mental health, there's still a general lack of awareness, and as CEO Ayemi said earlier, a taboo. But we hope the next few minutes will help address that. And let's start off with our colleague from Zambia, Pearl Chunga, the founder of the Walk With Me Foundation, who has been through a lived experience with mental ill health and is now through the other side, I hope, strong and ready to tell you what she's been through. Pearl, thank you very much for joining us. Can you share initially a little bit about your experiences struggling with mental health?
Thank you so much, Henry. Thank you everyone for joining us. Like Henry said, my name is Pearl Chunga from Zambia. I am diagnosed with chronic depression and generalized anxiety disorder. So that means I have depression that keeps coming back, goes away and keeps coming back, and I still have anxiety disorder. And I'm also an advocate for mental health and mental health services, not just any mental health care, but holistic mental health care. Mental health care that takes into consideration lived experiences like my own and all the other social aspects of mental health care. I was diagnosed with my mental health conditions when I was about 22 years old, and that wasn't the beginning of my struggle. My struggle actually started from the time I was about 13, and I knew there was definitely something wrong with me because I felt very different. My thoughts would always be all over the place. I would be thinking about suicide. I'd be thinking about hurting myself. I would react very badly to upcoming situations. So if I have an exam, anxiety, some level of anxiety is normal, but for me, it would be a whole nother level. I'd be throwing up. I wouldn't be able to get out of bed. There would be days I would wake up and I would be extremely sad. I couldn't pinpoint exactly what was making me this sad. And it started to interfere with my normal life, but I couldn't pinpoint it and figure out what the problem was. And eventually I started doing my own research. It wasn't getting better. It was only getting worse because I wasn't getting any help. So I started doing my own research, and eventually I figured out exactly what was wrong with me. And I decided to get treatment, and I started going out for therapy. But it wasn't something very easy. It wasn't something to speak about. I didn't easily have information accessible. It's not like when you have a headache. From the time you're 5 years old or 3 years old, you know to say that, okay, this part of my body is hurting, or I've got this headache, and to say, oh, I've got a tummy ache. But with mental health problems and depression or anxiety, for example, we don't grow up speaking about them. We're not openly taught about them in school. So I couldn't just openly go out and speak to my parents and tell them this is what's going on. And it took me myself going out there. Yeah.
Pearl, you're a highly articulate and engaging woman. I can feel your personality, a big personality coming at me all the way from Zambia to the UK, where I'm sitting at the moment. So I'm wondering what kind of stigma or discrimination you faced, if any, and how did it make you feel?
I still do, and I did even in the beginning. Even when I came out to my family and told them this is what's going on with me, and this is the help I want to get, the reaction I got was, why are you spilling your dirty laundry out in public? Why are you going to speak to people when us as your family are here? You should tell us about your problems. Those are not things you can go out and speak about. And when I did start to share my story, I think the reactions I was getting from both sides were very different. There was the people that showed me that I'm not the only one going through this. And there's so many other people going through the exact same struggles I'm going through, but they don't have a safe space to actually speak about their struggles. On the other hand, I had all these people coming out and telling me how I was just spoiled. I come from an ungrateful generation, and I should be grateful for what we have as a generation.
Spoiled millennial.
Yeah. Exactly. That's the reaction I got for coming out openly about it. So I think it was both sides. It showed me, coming out openly and speaking about my experiences showed me that more people need safe spaces. More people need somewhere where they can open up and actually speak about their experiences and these struggles that they're hiding because of society's stigma. But then on the other hand, I kind of understood exactly why they were hiding and not going out to get help, because there's so much thrown at you and so much said to you.
Okay.
Yeah.
So if the support from family and friends was, I'll be kind, patchy at best, what about the support from professionals, from clinicians, and what has been most helpful for you personally?
I think that was one of the greatest steps I took, going out to get professional help. I think it's the same thing when you have malaria or you have a tummy ache or a headache. You go out and see a physician and go out and see a doctor, and it should be the exact same thing with mental health. Go out there, they're actually very willing to help you. The mental health practitioners, the professionals are very willing and open to hold your hand through the treatment. My therapist was really amazing. She held my hand through the journey. She made me understand exactly where I'm coming from, why I'm at the point I am, and how I can get to a better place. It made me more self-aware and understand exactly what my situation and how to come out of the bad days when I do have bad days. I still have the bad days. Like I said, it's chronic depression, so it keeps coming back. But after therapy, and I still go back, I've kind of learned how to figure it out and how to go around it and come out of those bad days. Yeah.
And let's address the stigma and misconception, because you have received professional help. It wasn't terrifying, it wasn't scary, but did you fear that you were going to have to take medication? Because that is one of the reasons why there is so much stigma. Oh, you say there's something wrong with your mind, and therefore they're going to drug you up and turn you into some kind of zombie and put you away somewhere.
Definitely, that was my biggest fear when I went, and I think it was actually one of the first things I asked my my therapist was, will I have to go into medication if this is what you're saying is wrong with me? And she was like, no, okay, my first point of treatment would be to I'll assess you and see how you go with the therapy. If therapy doesn't work, we might have to try something else, and medication is definitely one of the options. So if you have to, it's the same as any other disease, is diabetes, any other illness that you take medication for. If you're not responding to one treatment, we'll move to the other one. And I was definitely scared of it, but I realized that there's nothing wrong with it. It's the same as any other physical ailment, and you can go out there and get your treatment, and it will help you get better.
Well, CEO Ayeyemi and Dr. Chido also talked about stigma and misconception, and you've set up the Walk With Me Foundation, which is great because most of the time when people get personal treatment, they keep it to themselves. They don't set up a foundation and try to advocate. Can you tell me how you're advocating and what kind of reception you're getting from the people and groups you're talking to.
So Walk With Me Foundation focuses a lot on, first of all, advocacy for mental health care. So trying to get mental health to a point where it's given equal opportunity or equal access as physical health. And we also try to go out there and increase awareness, make sure people understand, they know what these mental health problems are, they understand exactly what's going on with themselves, understand what's going on with the people around them. They have access to the information of where they can get treatment, what treatment is available to them. And we also have peer services where we connect users or potential users to professionals and also to peer support groups. Right now, as the foundation, our focus is on building a holistic model. We're working with partners in Zambia, stakeholders, to build a holistic treatment and recovery model for Zambia, which doesn't only focus on the medical aspect of mental health care, but it also focuses primarily on the social determinants as well.
Pearl, thank you very much indeed for joining us and talking to us about the Walk With Me Foundation based in Zambia. Now, you stand by. We'll be coming back to you a little bit later on when we have time for our Q&A. And if you look at the chat box, my people, you are bombarding us with your questions. So many are coming through. Keep them coming. We'll do our best to address them a little bit later on when we've heard from our next two speakers. But thank you so much for your attention and for those questions. Right, we're moving on from Pearl and Walk With Me Foundation to Dr. Ben Adesina Adinoye from the International Federation of the Red Cross and Red Crescent. Thank you very much, Dr. Ben. Now, my first question to you is about this. Let's say an emergency or a disaster hits and basic needs, food and shelter are being addressed, but then you've got to think about mental health. That's where you come in. Can you explain why that is a part of your work, why that is so important?
Thank you so much, Henry, and good afternoon to colleagues from Nairobi. I don't know if I can be heard.
You can.
Good. So, yeah.
Aha, you've disappeared for a second. We want to get you back. Let's hear your voice, Dr. Ben. I think you may be muted, so you need to unmute so we can hear you loud and clear.
So is it clear
yes.
now? Yeah.
You're back now. Yes, thank you. So please explain why IFRC Africa includes mental health as a vital part of its work.
Oh, no, thanks so much for that. That's a very important question because at the core of IFRC's response to humanitarian crisis is the provision of food, water, and shelter. However, just to put a bit of context to the question you have asked, why mental health in a disaster or humanitarian crisis? Dr. Chidu, while helping us to define and explain mental health, she clearly mentioned that is the state of optimal well-being of a human, whereby he's able to cope with issues and contribute to the society in a productive way. And we all know that when these disasters or conflicts or crises happen, there is a disequilibrium in the socio-economic environment or physical environment where these humans find themselves. And this disequilibrium invariably affects their emotional and psychological states. So this is why, as IFRC, the Red Cross movement, prioritizes the mainstreaming of mental health and psychosocial support in all our humanitarian responses to ensure that the disequilibrium that has been created by this disruption of either livelihood, a source of income, places of abode, source of water are addressed via our psychosocial first aid, as we call it, which is a very basic support that accompanies the other provision of water, shelter, and food that we give to this population or the affected population. And this is a very simple intervention that can be done in any place as far as it's conducive enough. The environment is created to be conducive enough for these people who are affected either to mourn, where there are situations of loss of lives, or to vent out their anger and frustrations in situations where they may have lost property and other valuables. So it's simple. A procedure carried out by our volunteers. They simply create the environment where they're able to look and respond to any danger that these people may have faced, and also listen to them actively to share their situations with them in an open and transparent and comfortable way. And in situations where some signals have been identified of a potential need for more advanced treatment or therapy, these people are referred to the appropriate facilities or organizations, depends on the context. So this is how it's done, and this is why it's important.
But Dr. Ben, as we heard from our previous speakers, it's hard enough to provide adequate mental health services in countries and regions where there's no conflict. So let's imagine you are a man or woman or family fleeing repression or fleeing conflict. Say, let's say in Tigray, in Ethiopia, you're maybe either internally displaced, or you've rushed across the border into Sudan. You are living day to day. You are highly dependent on any aid that's there. How on earth are you going to provide mental health services for people in those kind of distressing, extreme situations?
So first and foremost, as I mentioned, these are community-based interventions that are carried out by Red Cross volunteers who are on the ground, who in some instances are equally part of these populations we are talking about, are part of these communities we're talking about. So with this support we provide to them as International Federation of Red Cross, we are able to either create spaces, environment where these activities that are required can take place, either to listen to this population, either to refer them to appropriate authorities by linking to organizations. So this environment is created. But most importantly, other activities and actions are equally brought in, like teaching these people, the affected population, life skills, creating an environment for peer-to-peer support among those who are affected, and also creating activities around sporting, physical exercise, where these people can really engage themselves in things that are meaningful. And equally, in this context that you mentioned, their children, their family. So family-friendly activities are equally provided or created for this population of people. Child-friendly spaces are created where children can engage in recreational activities. So trying to really replay normalcy in the context you are describing now, Henry.
Mm-hmm. And Dr. Ben, Dr. Chido said the most common form of mental ill health is depression. What is the most common form of mental challenge that you see in those conflict areas, and what seems to be the most effective way of addressing those challenges?
So, like we're talking about acute situations now, something that just happens, a conflict happens, and people have to be displaced urgently. So you're going to see either loss of lives, you're going to see loss of property, so you're going to see people grieving, people who are emotionally traumatized. So these are the kind of initial acute things you see when such emergencies arise. So this is why for us is basic psychosocial first aid, as I mentioned, that we provide, which are tailor-made to the immediate needs of this population. So what this entails is that you organize group activities for these people because they share some similarities and commonalities in what they are experiencing. They are able to share their experiences. They are able to see that they have opportunity to be listened to by people, and also alternative pathways are suggested to them if the situation gets worse or continues to get worsen. They have referral opportunities that are provided to them. So these are the basic observations whenever an emergency strikes or humanitarian crisis strikes, and this is the aim of this psychosocial first aid that provides this initial care that ensures that the person is able to at least cope with the situation And if it worsens, then appropriate referral is done to competent authorities or organizations.
And Dr. Ben, finally, I mean, some of our viewers may be wondering where you're operating at the moment across Africa, because I mentioned Tigray and northern Ethiopia and the internally displaced people there, people living temporarily, we hope, across the border in Sudan, hopefully to come back into their country when it's more stable. But are there other parts of Africa where you're operating in numbers at the moment, where there's great concern for mental health?
Absolutely. So maybe as a way of introduction, the International Federation of Red Cross and Red Crescent is a secretariat of 191 Red Cross national societies across the globe, of which we have 55 in Africa, Africa as a continent, and the secretariat in Africa supports 49 of these member states, sub-Saharan Africa. So the 49 Red Cross national societies, sub-Saharan Africa, receive support from us. So as you rightly mentioned, we're present in Tigray, in Tigray and its surrounding places, Djibouti, where displaced populations have gone, Sudan, where some of the displaced people from Tigray have gone as well. We're there. Northern Nigeria, where we have the long-term crisis in northeastern Nigeria, the bordering areas of Cameroon as well. So across all these places in Africa where there are crises, our Red Cross national societies, as each country has its unique national society that is established by the act of the parliament to support humanitarian crisis. So everywhere there's humanitarian crisis in Africa at the moment, our national societies are supporting their national government to respond to the humanitarian crisis of the affected population in various ways, and of course, including mental health, which is a topic for now.
Dr. Ben, for now, thank you very much. You're going to stand by. You'll be joining us in a few minutes for our panel, and those questions are coming in thick and fast. I'm sure some of them will be directed towards you, Dr. Ben. So thank you very much for standing by. Finally, in our panel, let's introduce Mr. Michael Njenga, who is the Africa Advisor for CBM Global Disability Inclusion. Michael, thank you very much for joining us. First of all, tell us a little bit about CBM Global Disability Inclusion, because not everybody will be aware of what you do.
Thank you very much, Henry. So at CBM Global, we have a thematic area on community mental health, which focuses on a couple of things. And one of the most important things that we do focus is about the inclusion of persons with lived experiences and mental health condition in the society on an equal basis with others, because more than often we will have professionals and families speaking on their behalf. So that's very, very important to us. The second component is about strengthening health system, which is very, very important, ensuring that services are being provided within communities, and these services are acceptable, they are accessible, they are affordable, and they are of the right quality within their community. So the whole area of strengthening health system to ensure that we are delivering services in a way that promotes recovery and is in compliance with international human rights standard. That for me is a very, very important part of our work. So I think that's basically what really we focus on. And at the core of our work is, of course, the promotion of fundamental rights and freedoms of persons with mental health conditions who historically have been marginalized and left out of development processes, and also in terms of their inclusion in our communities. They face enormous barriers and challenges ranging from stigma, discrimination, social exclusion, and certainly the lack of proper investment, of course, from government in terms of ensuring that people are accessing comprehensive community-based mental health services within their community.
Right. Now, I'm just wondering how this fits into the status of mental health conditions within international human rights law. Are they recognized as a disability?
Yeah, yes, they do. So in 2006, the UN adopted an international treaty called the Convention on the Rights of Persons with Disability, and this to reaffirm the rights of persons with disabilities globally, because historically they have been marginalized, excluded, and of course they have faced a lot of human rights violations within our societies. And that is where we needed a convention on the rights of persons with disabilities to address those systematic and historical issues in terms of human rights violation and exclusion within our society. So I think what is very, very core about the convention is, first, is that it views persons with even mental health condition as persons with disabilities and as subjects before the law. So they have equal rights and equal responsibilities before the law, other than the traditional charity and medical view, where we just see them as objects to be cared for and managed. So we really don't think that they have a voice in terms of the things which affect them in their lives. So that for me is very, very important in terms of that. I think the second point is that the convention then shifts from a medical approach to disability to what we call a social or human right-based approach to disability. So the issue here is that the medical approach is about fixing the person. You cannot walk, we need to fix you. You cannot see, we need to fix you. You have a mental health condition, the problem is not you. The problem is not the barriers that exist within our society. So it conceptualizes the whole issue of disability from a medical perspective to a social and human right-based model. So, and I'll give one example. The problem with a person with a physical disability is not because they cannot walk. It is because our transport system are not accessible. Our buildings are not accessible. So even if they need to go attend a meeting somewhere, they cannot, even if they are qualified as a doctor or as an accountant, because there exist barriers within society which makes them not to be able to participate on an equal basis with others. So that is the whole evolution from the medical model to the social and the human rights model, where we recognize that disability arises from when I have an impairment, and this could be maybe bipolar, and there are attitudinal barriers in the society which hinders me from fully and effectively participating in the society on an equal basis with others. So that is one of the things that is really, really important in the convention, the shift from the medical model to a social and human right-based model in terms of the way we view disability.
All right. Well, Michael, it's one thing to have an international convention, a charter at a global level, UN level. What about if those rights, as you've described them, do not cascade to a national level, or indeed a regional level, or indeed at a work level? Say you're working in a bank or working for a government department and you're having issues, and the lofty charter and everything that is given you by this charter is not being recognized in your country or in your region or in your workplace.
Fine. Thank you very much. And I think that's a very good question. So there are a couple of issues when you're talking about human right-based approaches. So it's not just about having laws. There's what can be addressed by a law or inside a law, but we need to move beyond that. In order for us to implement laws, we need resources, which is very, very important. We need to develop programs. We need advocacy. We need to establish effective monitoring mechanisms, whether we are complying with international human rights standards in terms of how we deliver mental health services. So it's a question of, yes, we have laws, but then we need to provide resources to implement those particular laws, and we need effective monitoring mechanisms and the participation of persons with lived experiences in those processes through their representative organization. That is very, very critical.
Very, very important. And then when it comes to improvements in various African countries that you're working in, what are you seeing? Are you seeing the benefits of this advocacy? Are some of those employers or even national governments that didn't recognize that people with mental health conditions have human rights and that should be recognized? Is that perception beginning to shift now?
I think gradually it is beginning to shift. And I will start here. I'll start by saying about the global shift from the World Health Organization. The World Health Organization have adopted a new model. It's called the WHO Quality Rights Initiative. It focuses on two things: supporting services that are recovery oriented and promotes human rights. Because we cannot have mental health if we do not respect the fundamental rights and freedoms of the people who are affected by mental health condition. So I think for me, if WHO systematically is saying that we need to change the way we deliver services, and these services must be recovery oriented, and they must be embedded on fundamental rights and freedom, then I think that for me is a good starting point, because WHO generally will have a lot of influence at country level. Second thing is, of course, we are trying to develop legislation which complies with international human rights standards and practices. So, for example, one of the most contentious issues within mental health is the issue of forced treatment. The issue of forced hospitalization. And those are things which are prohibited within international human rights law, that we must respect the right of people to make decisions and to have those decisions respected by others. But normally that is not the case. For persons with mental health conditions, decisions are made on them by medical professionals, by families, by their friends, and that is why it's important to do that. So gradually, we are seeing changes as we engage with medical professionals, as we engage with government as the primary duty bearer, in terms of ensuring that they are respecting the human rights of people with mental health condition, they are protecting those particular rights, and most importantly, they have an obligation to fulfill and ensure that every person is enjoying the right to the highest attainable standard of health. And it's not about making laws, it's about also providing the necessary budgetary provision to be able to achieve that.
Excellent. Michael, thank you very much indeed for talking to us on behalf of CBM Inclusion. Dr. Adinoye and Ms. Chunga, thank you very much. I'm going to bring you all back. You've given us a lot to think about and really opened our eyes to what we personally should do and what we as organizations should do to help those struggling with their mental health. Dr. Chido, we need to bring you back as well, because I have asked my questions and I'm now going to turn things over to you, our audience, watching on YouTube, Facebook Live, and other platforms. The panel is standing by, and my word, the questions are still coming in. So this one is from William Danso. Hello, William, who's asking this: is there any research on common forms of mental health issues among bankers? And he wants to know, what are the top 5 causes of such? Now, who feels they're in a position to answer that? Dr. Chido, is there any research on this at all, do you know?
Talk about being put on the spot.
I know, but it's a really interesting question, because the mental health, time to talk and act, and it's Ecobank Day, and lots of bankers watching, and they're under a lot of pressure and a lot of stress. They're highly rewarded, but a lot of pressure. Common forms of mental health issues among bankers.
I'm actually just reminded about a study that was actually done here by one of the consulting firms, industrial psychologists here in Zimbabwe. So they looked at common mental health problems amongst in the corporate world. And again, as expected, depression popped up. So depression, anxiety was very big. Burnout was also very big. And funny enough, it's the middle managers who are most at risk. Probably because they have to juggle up managing and down managing. They looked. I remember that was one study that sort of popped out at me. But definitely there are studies that are there. It's very likely that it will reflect what is in the community, but more likely because of the high stress, high those deadlines that sometimes come in the corporate world. There'll be lots of anxiety as well. I've personally seen that with a number of my clients. Anxiety is quite high around the what do they call the month ends and quarter ends, and you really do feel sorry for them at that point. But
yes, think about the KPIs, key performance indicators, etc.
Yes. And I think one of the things that's important, and I know it will probably come up, is creating a better environment, psychologically safe workplaces. We really need to start thinking like that.
Right, we have another question, and this one is also targeted at you, Dr. Chido, and this is from Chris Lalahu from South Sudan. Thank you, Chris. And he says, please, can you distinguish between the following: depression and anxiety, mania and schizophrenia, and then personality disorders and psychotic disorders. Now, this is not a seminar purely focused on you, Dr. Chido, to give distinctions and descriptions, but in a nutshell, if you can, first of all, depression and anxiety.
So depression is both of them are mood disorders, but depression is more sadness, lack of motivation, and fatigue, and sort of just those sort of symptoms. Anxiety is worry. So anxiety is a fancy word for fear. So it's fearfulness, and it can be sort of a chronic fear, like generalized anxiety, sort of is always there. You actually start to think that's part of who you are. And then there's also the acute fear that can come with panic attacks. So when you get very, very scared and your heart races and you can't breathe and you have to sort of just get out of that situation that you're in, that's more anxiety. Mania is part of a condition called bipolar, not always, but most of the time part of bipolar, which is mood disorder, but it's a mood disorder that is changes from, you have phases where you have a lot of energy, a lot of a good mood, sort of almost pathological happiness, if you can call it that. You're too happy, but to a level where you're not functional anymore. And that's sort of some of the symptoms that come with it. You won't be sleeping, you probably won't be eating much. And then you have phases when they go into depression. And it's usually, it does run in families, not always, but it does. And then versus schizophrenia. So schizophrenia is a psychotic mental health or disease where you have hallucinations and delusions. You can also have them in mania, by the way, and in depression, by the way, if it's severe. But with schizophrenia, it's hallucinations, it's delusions, it's abnormalities in thinking, abnormalities in behavior, and abnormalities in the way you experience emotion. Yes, so we could do a whole seminar on all of these things, but in summary. And then personality disorders. Yes, that one is quite a difficult one. So there's a part of mental health where it has sort of been categorized differently from the other mental health problems because it can exist in coexistence with other mental health problems, and sometimes it can be something that can be very difficult to diagnose. So there's a number of them. There are like 12 different personality disorders that can happen. But basically, it's really struggling to interact with others and to function in the society in terms of your own personality challenges. So these can be issues like your emotional regulation can be a challenge with borderline personality disorder. It can be issues of antisocial personality disorder where you don't interact well with others, and there's a general lack of empathy, and you haven't quite managed to develop those skills. I think the key word with personality disorders is many times they are sort of generated by the environment that children and adolescents are brought up in, and then the personality has challenges in forming. The first 5 years are essential for personality development, and a lot of that can be prevented. Yeah.
And then psychotic disorder, then that's the other one, isn't it?
So psychotic disorder is really a general term, and it can be, you can have psychotic problems that are linked to medical problems. So people sometimes who have thyroid problems can end up with psychotic symptoms. People who have strokes can end up with psychotic symptoms. So it's really an umbrella term, and usually it's you would want to actually find out more and put a diagnosis to that to say where are those psychotic symptoms coming from. And psychotic symptoms are generally that loss of touch with reality, hallucinations, delusions, where you have sort of fixed false beliefs about things. Those are sort of the psychotic. And then thought disorders, where you can't sort of continue a chain of thought properly. Those are some of the psychotic symptoms. Yeah.
Thank you very much indeed, Dr. Chido. You did admirably to handle those definitions. And we've got a message, a short statement from Peace Afolabi. Thank you, Peace. I'm going to put this one your way, Pearl. I'm sure the family has a major role to play in this. That's a very short statement, but you could expand on that, because I saw you nodding vigorously at one point. What do you think? How would you respond to that? I'm sure the family has a major role to play in this.
Definitely.
Aha. You frozen, Pearl. Let's see. Yeah, you're back. Yes. Aha. We'll give you a second just to see if the picture comes back. Yes. Okay.
Okay. So I was saying the family did.
Okay. I'm going to go. Yeah, carry on now.
Interact with. Yeah, they're usually the closest people you interact with and the people you're with most of the time. So they do have, especially when it comes to your social aspect of your treatment and the social support, they're the structures that you live with, they're the people you're around all the time. And that definitely affects your mental health, both negatively and positively, depending on the sort of support that you're getting from the family structures.
All right, thank you very much for that. Now this is Mr. Dele Glenweye, who says, should herbal doctor treat mental disease? I'm going to give Dr. Chido first, and then our other colleagues briefly on this, because you may just have a yes or no answer, or you may want to expand. Dr. Chido, should herbal doctors treat mental disease? Because this is something that I'm sure is present in many African countries.
Okay. So I'll answer that by saying that mental health, just like most medical problems, are biological, psychological, social, and spiritual in nature. So when we're addressing them, you cannot completely exclude issues of spirituality, issues of culture. It's to our detriment in the medical system if we think we've got all the answers. But what I would encourage is for us to work together. So a collaborative approach where we say some of the issues we can address through the knowledge that we have learned in the medical system, and some of the issues can be addressed culturally and spiritually. And that sort of working together between the culture, the spiritual aspects, and the medical system. And that takes a lot of collaboration and respecting each other within the space so that can be achieved. So I won't say a straight yes or no. I think it's the individual who is seeking help from the herbalist should also consider that there are other aspects to their care, because biologically there might be things happening, psychologically might be things happening, spiritually there might be things happening as well.
Okay, thank you very much, Dr. Chido. Interesting that you are not hostile, because some medical practitioners, clinical practitioners are hostile to the traditional. Dr. Ben, is there an IFRC policy on this? If you're working in an area of conflict and there may be traditional healers or herbalists present, do you welcome them, or do you say, actually, we're not sure?
Thank you, Henry. So for us as Red Cross Red Crescent, we, of course, have a holistic approach. Number one, to addressing the public health challenges, and of course, mental health and psychosocial issues at community level, which entails via our community engagement and accountability mechanism, bringing everyone together, family members, traditional rulers, religious leaders, and all, to educate them, as Dr. Chido said. They need to have an understanding of what we are addressing here and what their role might likely be with respect to addressing the needs of either the individuals or the associated stigma or the misconceptions around such illnesses. So association of these groups are very keen, as Dr. Chido has said, and we work with them via the community engagement and accountability approach.
Thank you very much indeed, Dr. Ben. Michael, on behalf of CBM Inclusion, this question then, can you take it, should herbal doctors treat mental disease?
Yeah, so I'll just gonna reflect a bit on the experiences that we have in Kenya and how we work with traditional healers. I mean, we're talking in a context where mental health services are not available to most people, especially in the rural areas. So we have to recognize that. And people will go to traditional healers to be able to access, whichever kind of services that they are going to access from them. So I think for me, the issue here is to create a couple of things which we've been doing. First of all is to create collaborative efforts between traditional healers and other systems within our communities in order to address, mental health issues and mental distress. So that's one thing that we do. Secondly is creating referral system. We recognize that they have a role to play in terms of delivering services within our communities. So let's not create tension and fight one another. Can we create referral system and how all of us will work collectively towards addressing mental health issues in our communities? And the third, of course, issue is for us, especially because we are coming from a human rights perspective, is building their capacity to learn to respect the human rights, to treat people in, dignity, respect their integrity, respect their autonomy. So for me, looking at an African perspective, we really have to tap into the social capital and collectively work from there. But I believe that every stakeholders have a role to play, even as we build back better and try to remove inequalities that exist, of course, in the context of mental health.
Tremendous. Lots and lots of questions coming in, and we haven't got a huge amount of time left. So apologies for those questions we don't get to. And there are a number of questions for the bank. And the CEO, Mr. Ayeyemi, has had to had to leave us because he has another engagement. But questions for the bank will be addressed through the chat box or on other platforms with which the bank engages with. So thank you very much for those specific questions. But back to Dr. Chido, a question very specifically from Peace Afolabi. What are the symptoms of mental illness in children?
Very important question because we sometimes sideline the symptoms that children have. I think Pearl, in her testimony, was talking about how her symptoms started very early on and maybe were not even noticed in the family. So children do have symptoms. They can have emotional symptoms linked to depression and anxiety. They can have even psychotic disorders. It's not very common in children, but a lot of the mental health problems that we see in adulthood often have their sort of start in early adolescence. This is because the brain develops, it grows during the early childhood. By the time you get to adolescence, the brain starts to prune. It's a way of just getting rid of systems that it thinks are that have been strengthened, and those that haven't been strengthened are sort of gotten rid of. So the brain is changing, and you see that during the adolescent phase that we all know they're quite emotional and they can be quite difficult sometimes, and it's this transition phase that they go through, and it's that part is normal. But in a child who's predisposed to a mental health problem, you might start to see the problems there: depression, bipolar, even the psychotic symptoms can start around there. So the symptoms can be very similar to adults, actually. Like with depression, it will be the sadness, irritability, the lack of motivation. But in children particularly, things to do with school performance can be one of the first areas where you pick it up. Things to do with social interactions can one of the areas to pick it up as well. So those are some of the symptoms. And again, maybe here, just to put it there, because it might not come up later, also issues of signs of abuse. So signs of children who are physically, sexually, emotionally abused can have mental health psychological symptoms, and that can be one of the first signs that something is wrong, and then to engage the child and try and get them appropriate care.
Excellent. Now, I'm going to ask you all to be brief in your answers so we can get through as many questions in the remaining time. And this one is from Nvale Kuruma. Really interesting question. The best remedy to any disease is prevention. How to ensure prevention in the area of mental health? Any recommendations? Pearl, briefly. So you know about this. You've been through it. How do you protect yourself against any possible future mental ill health?
I think for me, on my personal experience, the best thing for me has been identifying what leads me into bad spaces. So being more self-aware and figuring out what my triggers are and drawing boundaries. So you need to know what's in my circle of control, what's outside my circle of control, what can I control and what can't I control. And once you have that figured out, I think it's a lot easier for you to adjust to different changes and different aspects of your life. And it's helped me tremendously.
Excellent. Michael, what would you say? Oh, I think you're muted. You're muted.
Yes, sorry, Henry. I think for me, one thing which I really say is critical in terms of prevention is we really have to look at the social determinants of health and how this connects to mental health. Because I keep on saying that if people are in abusive relationship, it doesn't matter which medication you give them, which therapy you give them. So I think we really have to look at the social determinants of health as an important way of trying to address, mental health issues. If people are living in abject poverty, we have to look at the intersection between poverty and maybe mental health. If people cannot access employment and be able to create sustainable livelihoods, I think that for me certainly affects their overall, mental well-being. So I think for me, we cannot see mental health just as a health issue alone. We have to look at the intersection between mental health, for example, and gender-based violence, and how do we start addressing that? Inadequate standard of living, lack of access to comprehensive mental health services. So for me, the whole issue of prevention we can't just see it from the lens of health, doing public awareness program alone. We really, really have to take seriously the issue of looking at the social determinants of health and how they contribute to the overall mental well-being of every citizen in every country.
Thank you very much for that. We've got a question for Dr. Ben. In which specific ways has the Red Cross addressed this issue of mental health as a result of the COVID-19 pandemic? You've sort of built that into one of your previous answers, but just to specifically address the question of Peace Afolabi.
Okay, good. So now, for the sake of time, I will just give two examples and maybe specific examples. So in the wake of COVID-19, as you all know, we had various degrees of lockdown, restriction of movements across many of our communities and states. So one of the things that our Red Cross National Societies did was to ensure that people who required lay counseling, speaking to people, could still access such services through hotlines that they established to communicate and engage with people. People had curiosity, questions, they were anxious. So these hotlines helped to answer those. Then another way, in somewhere like Niger, where predominantly Muslim country, where burials are done in specific ways, the Red Cross volunteers there had to be supporting people who lost precious ones to COVID in the burial ceremonies, because, of course, as was explained earlier by Dr. Chido, there were so many protocols about burial during COVID. So the volunteers had to intervene here, assist the families in the burials, in the prayers, and also in providing grieving support to family members. So these are just two examples, but there are many more examples which we can share via the report of what the Red Cross National Societies are doing. in the context of COVID-19. Thank you.
Thank you very much. And question for Dr. Chido here. Any suggestions of how to assist a friend or family member who's exhibiting signs of mental health challenges but is refusing to seek professional help?
Okay, I think Michael touched on this, and I'll emphasize it as well. So there's a great need to respect autonomy and also to preserve dignity. So a lot of the times when we feel, okay, someone has a problem, we are pushed, or it might be from a good place, but you want to intervene before that person might be ready to get the help that they need. So it's very important to start to engage with the person and tell them what your worries are as a family member, the concerns that you have, and then introduce the idea of going to see a medical professional about it. And it's always very important to emphasize that there is no need to, this is not going to be a forced process, to really be quite gentle and accommodating. It takes longer to get someone engaged in treatment that way, but it's well worth it. And I don't know, I think it was Michael again who mentioned the Quality Rights Initiative. It's a course that even family members can do so that they actually understand how to engage with someone who is having mental health problems in a dignified way. So it does take longer than the way we were traditionally trained to say you invoke the Mental Health Act and here we go. But many times if you do take your time, you can. And it's very important also to note that people can be aware that they're not well. Yes, yeah.
And Pearl, any thoughts on that? I mean, you were the one who initiated your own treatment plan. You know, you went to see family and friends, and then you went to see a clinician. But what about people who don't want to seek help, but the family members can see something is wrong and they're refusing?
I think for me that has been a really tough one, even just for me working in the community and working in peer support. There's so many people that you come across and they're not willing to get help. But what I've found is, I think them not willing to get help or them just refusing that there's nothing wrong, most of the time comes from, one, the stigma that's associated with having a mental health problem. So they don't want to accept that they've got that problem because of the way everyone else will react. So once you actually create those safe spaces and show them and assure them that there's nothing wrong with what you're going through, and make sure you're going through it like in a dignified way, like everyone else has said, I think it makes it a lot easier for those people actually to start to come to terms with actually getting help and going out there and seeking help.
Excellent, thank you for that. Michael, can you take this one? This is from Milka Kimondo, who says, I think one of the things that keeps people from seeking help is that the medicine and consultation services are quite expensive. That is true, isn't it? Oh, you're on mute.
Sorry. Absolutely, and thank you very much. And I think that's quite true, especially within an African context. And this is first of all, of course, because of a lack of investment in community-based mental health services. For me, that's very, very important. And integrating mental health into the general health system. So, for example, in Kenya, we have a huge problem that most people want to come to our main institution, which is called Mathare. And I'm imagining someone have to travel 500, 300 kilometers to come and access services there. So for me, that's basically one issue. So it's the whole issue that we need to be able to access services within our communities in order for us to be able to eliminate that particular barrier. The second thing is the primary obligation is on the government. It's not a question of developing laws, but we must allocate adequate resources to be able to implement comprehensive mental health services in our countries. Because one of the biggest issues is actually the issue of budget. Most countries will allocate, I think, less than 1% of their health budget to mental health. and most of this is going to supporting institutions. It is not being taken to community-based, services. So I agree. And then you look, for example, at insurance in Kenya. It is very discriminatory that even when you have insurance, they are putting caps in terms of the benefits you can get if I'm going to the hospital to access, mental health services and all that. So I think it's a whole lot of, systematic issues and problems that needs to be addressed. And I think for me, I keep on going back that it is a high time as we build back better from the pandemic to ensure that we're investing in community-based mental health services and taking away money from institutions, leaving them to handle the most difficult issues and to deal with research.
All right. Thank you very much, Michael. This one has come in from Tressa Ombolo, who asks, does frequent computer use have an impact on mental health? If so, what advice can you give to teleworkers? That's interesting, Dr. Chido, isn't it? Because we spend so much time now looking at our laptops, our tablets, our phones. We almost never switch off. Can they contribute to a decline in mental health, do you think? And if so, what can we do about it, especially if you're teleworkers?
I think it's an important thing that has been brought up that we probably had overlooked. So it comes back to social interactions. Human beings are social beings, and there is a need for interacting with a real person, not over the screen. So there is need for work-life balance, particularly for someone who's a teleworker or working remotely. There's that need for that balance. I think during the whole COVID lockdown, we used to push a lot to say you need to be able to structure your life even better than you did when you were going to work in a physical office. You have to be a lot stricter with yourself to say this is work time, and then there's time for family, time to interact with friends, time for a walk outside, so that you balance your life out. Then the second thing is social media. We cannot ignore that, particularly for the younger people. Our young people are struggling. They've lived in a world that we didn't grow up in. Where there's a lot of emphasis on social media, and that can have a detrimental effect on mental health, and actually has been associated with depression and anxiety in adolescents, excessive social media use. So that's something that we also need to be wary of. Even as adults, I think we're partly addicted to our phones and our devices, and we need to be able to switch off. Be strict. The phone needs a bedtime, just like you need a bedtime.
Right, thank you, Dr. Chido. Here's one that comes up every so often. This is from Joseph Yo-Yo, who asks, what is your take on demon possession as far as mental ill health is concerned? And Dr. Chido, in your opening remarks, interaction with me, we did address this to a degree. People think there's a spiritual sickness or a curse or possession, and this is something that was common all over the world, until fairly recent history, not just in African countries. But Dr. Chido, your thoughts briefly on that, and I think our other panelists may have encountered this question before. Dr. Chido.
So it comes back to acknowledging spirituality and not downplaying it. So as a practitioner myself, I cannot receive a patient and then ignore the aspects of spirituality that they hold dear and they feel are important, because in the recovery process that will necessarily that needs to be addressed as well. So again, it comes.
But Dr. Chido, I assume you would never diagnose somebody with demonic possession, as people used to.
No, I wouldn't. But if they come in and they feel that part of their symptoms are due to demon possession, I cannot ignore that. I cannot disregard it or disregard what the family is saying. So you need to be accommodating to say, okay, this might be part of the problem, but through education and really attacking the disinformation, you'll be able to give them information to say, you know what, this condition also happens in these areas. It happens to other people, and it may be that there might be other causes to it. Can we also address it in this way, as you also address this with your family or with your pastors or wherever it is that where you feel the demon possession can be addressed? It's a collaborative approach. When I was younger as a psychiatrist, you'd want to push the medical model a lot more, but I've grown and known that people have their beliefs, and you cannot always dispel them. So you work around them. So we don't diagnose people with demon possession, but we acknowledge their beliefs, and we work within those beliefs as long as they're not violating people's rights, tying up people in shrines. That is not right, because that is not protecting the dignity of the person, and that is not African either, the idea of taking away someone's dignity. So we work around it. Yes, yeah.
Fantastic. Dr. Ben, briefly on this?
I'll be brief because I know we're short of time. I completely agree with Dr. Chido, and maybe to buttress that with our standpoint as I4C, where we work from, we say saving lives and changing minds. And we change minds by working with the people, by engaging with the people, by respecting their beliefs, and of course, respecting their dignity as humans. So thank you. This will just be my response. Over.
Tremendous. Michael, your closing thoughts on that?
Yeah, just to give a very simple example that in one of the projects which I was working on, this person had a mental illness, and the family and him were saying because they had not paid dowry, and then this is not something that we can just not push away. So, for me, the issue was fine. Within my culture, you have to pay dowry, but at the end of the day, also you have a certain diagnosis. So let's deal with those two things. So I don't want to just push and say that what you're saying is not important. So if you have to pay dowry, pay dowry. But at the end of the day, you have a diagnosis and you have a treatment plan. Can we also follow that? And I think it's what the other colleagues have said. It's a process of negotiating and not just pushing people back, and appreciating the role that religion and culture plays within an African context.
Excellent. Okay, thank you, Michael. And final 30 seconds has to go to you. Pearl, walk with me, walk with us. Your closing thoughts on this?
I think the biggest thing is collaboration and dealing with it in a collaborative approach. So not pushing aside religion, not pushing aside spirituality, and also not pushing aside the medical aspect of it. It has to be a collaborative approach. You have to do it in such a way that you're working with the community leaders, you're working with their religious leaders, and also the psychiatrists themselves and all the other mental health professionals to make sure that it's a holistic and collaborative treatment model.
Tremendous. Thank you very much indeed to Ms. Chunga, to Dr. Chido, to Ms. Njenga, and Dr. Adinoye. Tremendous panel. Thanks to all those of you who sent in those really pertinent questions. We've learned a lot today, haven't we? It's about collaborative approach. It's not binary. It's about reaching out. It's about abolishing stigma. It's about taking early intervention. It's about trust. And it's about human rights. So many things that we've learned today. So thanks to all those of you who have tuned in for the Ecobank Day webinar. It's time to really act on mental health. It's time to talk and act. Have a look at the QR code there. You can scan it and it will give you a toolkit which will help you and tell you where to go for the next steps. But for me, Henry Bonsu, and the entire Ecobank Day team, thank you very much for joining us. And until next time, goodbye.